very good also. Learning through national and international faculty and updating our knowledge through many webinars and conferences has brought very positive outcome. And telemedicine and teleconsultation in are our new way of practice. We have also seen some of the fastest advancement in global medicine in our lifetime. Discovery of a new pathogens to roll out of a vaccine in less than 12 months is a big achievement, and transformation of OPD activities to the virtual world is changing the pattern of practice. Successful multi-centering drug trials on a scale never seen before, increased number of publications and articles in journals never seen before. But after all, what is important, we did not forget that human life is very precious and must be valued. And we all healthcare professionals were trying hard to fight COVID and save human life. And in that process, we have lost many of our health professionals, which is really one of the worst outcome of COVID-19. I, on behalf of API and Scientific Committee Society, APICON 2019, pay homage and respect to them for their sacrifice. Friends, I would like to extend my sincere thanks and gratitude to the learned speakers who are updating us today, and I hope we will be, this discussion of today is a great opportunity for us to update on COVID-19 infection and the post-COVID complications. So thank you very much, all of you. And I request Dr. Girish Mathur to go forward for this flow of events. Thank you so much.
Thank you, sir. Honorable Dr. K K Pareek, sir, past President API, past Dean ICP, my mentor and guide, and father figure of Rajasthan API. Dr. Pradyumn Sharma, anchor of today's webinar. Dr. G. Ramchandani, seniors and friends. Friends, although India is poised to cross 1 crore mark of COVID patients in almost 2-3 days, but there is a rapid decline in infectivity rate and number of deaths in our country during last fortnight. And with the availability of COVID vaccine on the cards, we are finally started seeing silver lining in the dark. But there is no room to lower the guard. We need to keep ourselves updated with the current challenges in COVID management. And to update ourselves this evening, we have a panel of highly acclaimed pulmonologists. We have Dr. Raja Dhar. It is a respiratory disease specialist of international repute. We have Dr. Shubham Sharma. He is a pulmonologist at Fortis Hospital, Kolkata. And we have Dr. Vivek Singh. He is a transplant pulmonologist at KIMS, Hyderabad. Dr. Raja Dhar is head of department pulmonology, Fortis Hospital, Kolkata. He is also director research and education, National Allergy, Asthma, Bronchitis Institute, Kolkata. He is the Indian representative for the ERS. He is also honorary executive committee member of the Indian Chest Society. He is examiner for the MRCP in UK and India. And he has a large number of international and national publications to his credit. We also have thus Dr. Shubham Sharma. Dr. Sharma is pulmonologist at Fortis Hospital, Kolkata. And a third speaker of this evening is Dr. Vivek Singh. He is transplant pulmonologist at KIMS, Hyderabad. Now I invite Dr. Raja Dhar and Dr. Shubham Sharma for their presentation of this evening. Ajay, please start the proceedings.
Ajay, unmute him.
आवाज नहीं आ रही सर।
ये वॉइस नहीं है।
Ajay, कुछ आवाज नहीं आ रही बेटा।
Please unmute it. Not getting voice.
ये कुछ हो ही नहीं रहा।
Ajay,
You are not audible.
Ajay, there is some internet problem at his end. Ajay,
Dr.Raja, you are not audible.
सुन ले भाई, अपने बोले जा रहा है।
You are not audible.
बोल रहे हैं, सुनाई दे रहा।
There is.
अगर वाला बोले जा रहा है, सुनाई दे रहा है।
बना ही नहीं हो।
अरे कम कर यार, कम कर यार। हाँ, थोड़ी कम कर। अरे भगवान, क्या है? चल रहने दे, चल ले।
पहले ट्राई नहीं किया था क्या बेटा? अच्छा ठीक है, ओके, थैंक यू। देखता हूँ बेटा। नहीं आ रही, नहीं आ रही बेटा। नहीं आ रही।
Your voice is not coming. Dr. Raja Dhar?
No. Problem actually, he has sent his talk.
एक मिनट
Initial
डॉक्टर साहब,
talk.
एक मिनट डॉक्टर साहब, एक मिनट।
नहीं, मैंने कल सुना था सर, बढ़िया आ रही थी आवाज, इट वाज क्लियर।
नहीं, पर अभी क्या हुआ?
आई डू नॉट नो।
लो दोबारा से।
तो या तो फोन करो उनको आप।
हाँ, कर रहे।
वो बोले जा रहा है, उसको सुनाई दे रहा।
हाँ, उनको रिंग करना पड़ेगा।
हाँ, कर रहे। वो कुछ गड़बड़ है, मेरे को लगता है वहाँ इंटरनेट की प्रॉब्लम हो रही है।
सर अभी नहीं आ रही, इसमें तो शो कर रही है सर।
कैसे करें यार?
आपने जिस व्यक्ति को कॉल किया,
कैसे करें बता?
मैं कुछ करता हूँ सर, एक मिनट।
हाँ, मतलब वो पहले ही करना चाहिए था एक बार कोशिश।
सर मैंने चला के देखा था, चल रहा था सर।
नहीं,
एक मिनट
नहीं देखा।
मैं करता हूँ।
वो ना बोल रहे हैं।
फोन नहीं लग रहा उनका।
Talk recorded लग रहा है।
आवाज नहीं आ रही है।
मैं उनको सर ऐसा करते हैं, मेरा रिक्वेस्ट है डॉक्टर विवेक सिंह को ले लेते हैं हैदराबाद।
If he's अगर बात करना है, if he's available, अभी है?
नहीं, मेरी बात हो गई है, he is available, तो अपन पहले ऑर्गन ट्रांसप्लांट ले लेते हैं लंग ट्रांसप्लांट पे सर,
ठीक है, बेटर
है ना?
हाँ।
बाय द टाइम वो अजय इनको कनेक्टिविटी चेक करते हैं, तो वी रिक्वेस्ट डॉक्टर विवेक सिंह,
ठीक है, फाइन फाइन,
है ना सर? तो अजय, डॉक्टर विवेक सिंह को ले लो आप पहले हैदराबाद से।
सर अगर मेरे को स्क्रीन शेयर करने दे तो।
हाँ, अजय सर का स्क्रीन शेयर करने दो। अजय,
डॉक्टर विवेक सिंह को इंट्रोड्यूस कर दें, डॉक्टर माथुर।
हाँ सर, मैं कर देता हूँ इंट्रोड्यूस, वो उनका
आप कर दो, आप कर दो, आप कर दो, आप कर दो।
वो अजय को कहना पड़ेगा वो स्लाइड लगाए उनकी सर।
हाँ लग गई सर, आई एम एबल टू, एम आई ऑडिबल?
Yes,
यू आर
yes, yes.
ऑडिबल, बस आपका वो स्लाइड शेयर हो जाए सर।
And can you see my, I am sharing my screen, can you see my slides?
नहीं
No
सर,
slides are not seen.
नहीं आ रही।
स्क्रीन तो मैं शेयर कर रहा हूँ सर।
हाँ वो अजय जी, अरे अजय सुनो,
ये आ गया डॉक्टर साहब, इनका चालू कर दिया, दिखता है उसने।
नहीं सर ऐसा करते हैं पहले, हाँ ये डॉक्टर विवेक का ले रहे हैं अपन।
Yes, your slides are being seen.
Okay, so should I start?
हाँ
Yes,
सर,
sir,
मैं
yes,
आपको
sir,
इंट्रोड्यूस
yes.
कर देता हूँ, एक मिनट।
Sure sir, sure.
अजय प्लीज।
यार ये क्या हो
मेरा
रहा
फोन जा रहा
है?
है अजय को। अजय वो उनका बंद कर दो, डॉक्टर विवेक सिंह आवाज कहाँ से आ रही है? ये बंद, आवाज कहाँ से आ रही है? तो एक बार चेक करो।
ये अनम्यूट करो यार।
हाँ यस सर। सो
हाँ,
dear
विवेक
friends,
सिंह को, हाँ,
dear
yes.
friends, we have Dr. Vivek Singh. He's a transplant pulmonologist with us, working on a lung transplant. And if you go in the history, 1953 was a day when kidney transplant took first time for humankind. Followed by 1963, it was a human lung transplant was done, and more than 51,000 transplants have been done. अभी आपको ये जान के बहुत खुशी होगी, टाइम्स ऑफ इंडिया, नव भारत, सभी में, इंडियन डेली न्यूज़पेपर्स में 11 दिसंबर को एक बहुत बड़ी न्यूज थी। एंड उसमें किम्स हॉस्पिटल में एक 34 ईयर पेशेंट का, जो कि हरियाणा से पेशेंट था एंड कोविड हुआ था, जिसके दोनों फेफड़े खराब हो गए थे, वहां किम्स में उसका डबल लंग ट्रांसप्लांट बड़ा सक्सेसफुल हुआ। एंड वी ऑल अप्रिशिएट, इसके लिए मैं सभी से कहता हूँ एक बार ताली बजा करके हम किम्स हॉस्पिटल के लिए, जो कि डॉक्टर विवेक सिंह साहब एंड डॉक्टर संदीप बटावर इनके नेतृत्व में ये डबल लंग ट्रांसप्लांट हुआ। सो हमारी आज बहुत खुशी का दिन है। We are already really honored to have Dr. Vivek Singh, who is doing very good surgery. More than 250 transplant surgeries they have done. I request Dr. Vivek Singh to please take over and just kindly come with the details of the lung transplant.
Thank you, sir. Thank you very much for a very kind introduction. First and foremost, I would like to thank all of you on behalf of the Institute of Heart and Lung Transplant at KIMS Hyderabad for giving us such a nice introduction and saying such nice words about us. So, of course, this was just to give a brief of this case. So, this was a young 34-year-old gentleman who was diagnosed to have COVID. And unluckily, in spite of all the respiratory supports, he continued to have worsening respiratory failure. So when we saw him, he was not even maintaining on ventilator. So he was initiated on the ECMO and we shifted him to Hyderabad. Once we got him to Hyderabad, there were few challenges with us that he was growing a Klebsiella in his blood, though he was not having septic shock, but he had sepsis. And he was grossly deconditioned because he was already admitted in the hospital for close to around 3 weeks before we shifted him to Hyderabad. but we were very happy to say that we could manage him, we could clear off his infections, and then finally we gave him a double lung transplant. And uh, it's heartening to share that yesterday this patient walked out of the hospital without oxygen on his feet. This case also has one more landmark attached to it, that this is the longest bridge of ECMO which has been used in India for a lung transplant. We bridged this patient for 53 days on an ECMO. The longest run in the world, it has been 62 days in this COVID era in China, and we are very, very proud to say that we did it for 53 days successfully. So this was a brief about this case. Now, just talking about lung transplantation. So we do agree that lung transplantation is still into infancy in India. Not many centers are doing it, and still people have a lot of questions about lung transplant. So on this presentation, I've tried to cover up lung transplant on a very, very broad basis and special touching points to COVID, because this is something all of us are facing. So when we look at it, okay, so between 1963 and 1983, there were around 44 unsuccessful attempts at lung transplant across the globe. And it was only in the 80s that we started seeing success with lung transplantation. One of the reasons attributed to it was the advent of cyclosporin, which was a landmark in immunosuppression. And in 1983, at the Toronto General Hospital, the first successful single lung transplant was done, and they followed it 3 years later with the first successful double lung transplant. When we look at the number of transplants, as we see that according to the International Society of Heart and Lung Transplant, over the last 30 years, the number of lung transplants have grown. But what is noticeable here is the majority of lung transplants are happening still in the Western world, particularly the North Americas. As we have grown and gained more and more experience with lung transplantation, now more and more centers are doing more double or bilateral lung transplants compared to single lung transplants. But this is what we look at. So though there are a lot of centers who are doing lung transplant, but around 33% of lung transplants are done only by 15 centers. So across, for all the transplants which are happening across the globe, 1/3 is being done by only a very few centers who do more than 50 transplants a year. Majority of centers are doing less than 20 transplants a year. So still centers need to gain more experience, and more centers need to pick it up. When we look at the adult, the recipient age by the year, as this graph would show that as the years have passed by and we have gained more and more experience, and we are improving our techniques of lung transplant, we are becoming more and more aggressive, and we are transplanting more and more older patients. So if you look at in the 80s, when the transplant just started, the median age for our recipients were close to around 40 years, but now we are transplanting more and more older individuals, and the median age has slowly grown, and it is close to around 62 years across the globe now. Similarly, we're the donor age. Now with better assessment techniques, better management techniques for the transplant patients, we are choosing even older donors now. This is one question which has always been asked, that what's the survival post lung transplant? So when you look at it, the median survival for lung transplant is close to around 6.2 years for adults and around 5.7 years for the pediatrics. So by this we mean that around 51%. So at 6.2 years, the survival, around 51% of people are doing well. When we talk of the year-wise survival, it is 90% at 1 year, and 51% at around 6.2 years, and 31% at 10 years. When we look between the primary and a retransplant, of course, the primary transplants tend to fare a little better compared to retransplants, and because of reasons which are very obvious, that the immunology and the rejections much more in retransplants because they are more sensitized patients compared to patients who are receiving their first transplant. Coming to major indications for lung transplantation, if we look at it, initially COPD use was the major reason for lung transplantation, but over the years, particularly after the year 2005, ILD, particularly IPF, has picked up, and now more transplants are being done for IPF compared to COPD. The other causes for transplant, for which transplant can be offered, are non-IPF ILD, cystic fibrosis or bronchiectasis, alpha-1 antitrypsin deficiency, certain rare causes as well, like LAM and Langerhans histiocytosis, sarcoidosis, and pulmonary arterial hypertension are also conditions which can be treated by transplantation. And of course, a small percentage of transplants is the retransplant. But in India, still retransplantation is not something what we are doing. Our major indication for transplantation is interstitial lung disease, particularly IPF and fibrotic NSIPs, and of course, pulmonary arterial hypertension. Now the question comes, who to transplant? So when we look at patients who can be considered for transplant, first on a very general perspective, the patients should have a very high risk of dying from the lung disease within a 2-year period if a lung transplantation is not offered. The patient should have a very high likelihood of surviving at least 3 months after lung transplantation. That is, their overall general health should be good. They should not be suffering from any other end stage or incurable disease. And they should have a high percentage, more than 80% likelihood of a 5-year post-transplant survival from a general medicine's perspective, provided if there is an adequate graft function. So if a patient qualifies these 3 criteria, that is, he or she should have a very high risk of dying from the lung disease, should be surviving at least 90 days after lung transplantation, and should have a more than 80% likelihood of survival for a 5-year period from a general medicine perspective, then lung transplantation can be considered in such patients. What are the contraindications for doing lung transplantation? A recent history of malignancy. We need a 3-year malignancy-free period before anybody can be considered for lung transplantation. The patient should not have an untreatable dysfunction of any other major organ function, should not have uncorrected atherosclerotic disease, acute medical instability. Now this, this has moved to a relative contraindication phase rather than an absolute contraindication. Should not have uncorrectable bleeding diastasis, should not be having any substance abuse. We need at least 6 months smoking-free period. No chronic infections, no active Mycobacterium tuberculosis infections, significant chest wall deformity, class 2 or class 3 obesity. So our acceptable BMI, nobody should be more than a BMI of 30, and our most acceptable BMI is anywhere between 19 to 24. Should not have any psychiatric illnesses, and should not be severely limited functional status. So for somebody to be considered for transplant, they should be walking at least 250 meters on a 6-minute walk test. On the relative contraindications, we say age more than 65. So this is a relative because some of the centers do it, some of the centers do not. We take patients up to 70 years of age if they have no major comorbidities and they are in a good physical status. Severe osteoporosis, mechanical ventilation or ECMO. Initially, this was absolute contraindication, but now it's a relative contraindication, particularly in this COVID times when a lot of transplants are being done of ECMO. Now, coming to the disease-specific criteria, as I said, COPD was one of the leading causes, now also remains one of the leading causes across the globe for transplantation. And a referral to a transplantation unit should be considered in patients who continue to deteriorate despite optimal medical and surgical therapy. When should a referral be made? Any patient with COPD having a board index of more than 6 should be referred. And they are transplanted when they have a board index of 7 to 10, along with either a history of hospitalization for an exacerbation, which is associated either with an acute type 2 respiratory failure, that is a PCO2 of more than 50, or they have pulmonary hypertension or cor pulmonale, or both despite having being on oxygen therapy, or people who have FEV1 less than 20% of predicted, or DLCO less than 20% of predicted, or they have a homogeneous distribution of emphysema, that is, they're not candidates for lung volume reduction surgery. For IPF and UIP, now these are the, I shouldn't say the second most, but they in India, they are the leading cause for lung transplantation. And what we have to remember is that patients with IPF have the highest on waiting list mortality because they tend to deteriorate very, very fast. Lung transplant comes with a waiting period. So this particular disease has the highest mortality while patients are waiting on the transplant waiting list. When should a patient be referred or considered for transplant? They say whenever a diagnosis of UIP, IPF is made, at the same time, patient should be talked about lung transplantation, and opinion should be sought from a lung transplant unit, irrespective of what their lung functions are. Similarly, patients with histological evidence of fibrotic NSIP should be referred for an opinion from the transplant unit. These patients should be taken for transplant when they have histologic or radiographic evidence of UIP, along with a DLCO less than 39% predicted, or there is a 10% or more fall in the FVC during a 6 months follow-up period, when they start desaturating to less than 88% on 6-minute walk test, or they have a honeycombing on the CT scan. For the NSIP, the only difference is that compared to UIP, when the DLCO is less than 35% predicted, they should be considered for transplant. Rest criteria remains the same, that there is a 10% or more fall in the FVC on a 6-minute walk test, or there is a 15% fall in the DLCO. For PAH, such patients should be sent to a transplant unit when they have class 3 or class 4 breathlessness despite being on medical therapy, or they have a rapidly progressive disease. They should be transplanted when they have continue to have 3 or 4 class breathlessness despite being on maximal medical therapy, that is on a combination of 3 drugs along with supplemental oxygen. When they have low or declining 6-minute walk test, when the cardiac index is less than 2 liters per minute per meter square, or when the right atrial pressure starts exceeding 15 millimeters of mercury. CF or other causes of bronchiectasis, of course, CF is not that commonly diagnosed in India, but we have a lot of bronchiectasis, particularly post-tubercular sequelae on our lungs. So these are this is the third most common indication for which lung transplantation is performed. And what I want to reiterate is pre-transplant colonization with a multi-drug or a pan-drug resistant organism in the lungs is not a contraindication to transplant, because it has been seen that it has no significant influence on a short-term survival, that is the in-hospital mortality. These patients with bronchiectasis, when they have a FEV1 of less than 30% of predicted, or there's a rapid decline in the FEV1, should be considered for transplantation. When they have frequent exacerbations requiring ICU admissions and frequent antibiotic therapy, if they have refractory or recurrent pneumothorax, or they have recurrent hemopsis, which is not controlled by bronchial artery embolization, they should be considered for transplantation. They are transplanted when they have oxygen-dependent respiratory failure, or they start developing a type 2 respiratory failure or pulmonary arterial hypertension. Similarly, for sarcoidosis, whenever they have these patients starts having breathlessness class 3 or class 4, they should be referred. They are transplanted when they start developing hypoxemic rest or PAH, or the right atrial pressure starts going more than 15 millimeters of mercury. For these rare diseases like the lymphangioliomyomatosis. So until a few years ago, the treatment used to revolve around sirolimus and the medical management, but now consensus has arisen that lung transplantation is the best treatment option for such patients, and they should be transplanted when there's severe impairment of lung functions and exercise capacity of these patients, or they start developing type 1 respiratory failure. Now, coming to lung transplant in COVID survivors. Now, this is a new indication which has been added to our list of indications for lung transplantation. So, lung transplant can be considered in 3 phenotypes of patients with COVID. Either patients who have end-stage lung disease and they have a COVID exacerbation or infection. When a patient, otherwise healthy patient, develops a post-COVID fibrosis, or post-COVID lung damage, which is warranting these patients to be on life support. That is, we cannot, because of the damage to the lung as a result of the COVID infection, these patients cannot be weaned off from the ventilator or ECMO, then such patients can be considered for lung transplantation. From a general perspective, age should be, for COVID patients, the age should be less than 65 years of age. It should be a single organ dysfunction of the lung. All other body functions, body organ function should be normal. The time duration from the initial signs of respiratory failure to transplantation should not be less than 4 to 6 weeks. So the consensus which is there at the moment is that if 4 to 6 weeks have arisen from the time of initial signs of respiratory failure, which is not improved, they can be considered for lung transplantation. These patients should have no other contraindications, as I highlighted earlier, for lung transplantation. The general condition should be favorable for pulmonary rehabilitation while these patients are awaiting transplant. So our preferred way of bridging these patients for lung transplantation is ECMO rather than ventilator. So this is a simple reason that we can make these patients awake. They are on, only on minimal ventilatory supports, just at the FRC or with some pressure support ventilation just to support their muscles. And these patients are kept fully awake, and our physiotherapists continuously work with them with on-bed physio. Some of these patients who have a single site cannulation in the jugular, they are even, we prefer them that they should be moving with our physiotherapist with the ECMO. Patients should not be improving despite optimal medical therapy, and there should be no evidence of sepsis. So these patients with COVID can always be considered for lung transplantation. But lung transplantation, as I said, this is a treatment which has some issues with it. Of course, these patients have to be on lifelong immunosuppression, as a result of which they're more prone for some infections. There are episodes of rejection. They, you know, on a long term, they have increased risk of cancer, and of course, graft failure remains always an issue. So if you look at the causes of death after lung transplantation, so within the first month of transplant, if we look at it, the most common reason for death is the graft failure. That is the allograft which we give fails to take off. There is dysfunction with the organ, and the patient cannot make through it. Infections, of course, remain one of the causes, particularly the donor-related infection. In India, this is a particular concern. But as we move out of transplant, during the first year, infection, so between the first month, so once they're discharged from the hospital, infections are the leading cause of death. And gradually, as we move out of transplant period, the graft failure or the chronic lung allograft dysfunction becomes the leading cause of death of these patients. When we come to infections, I'll just briefly go through it. So within the first month, it is the viral, the bacterial or the fungal infections, particularly the donor-related infections, which are the major cause of death. As we move out during the first 6 months, that's where the other viral infections, particularly the CMV, the pneumocystis, start taking a role. Of course, all these patients are on CMV prophylaxis for the first year, and pneumocystis prophylaxis for their life. And gradually, as of course, the bacteria and the fungus will always remain a concern. In India, we have seen that Aspergillus is particularly an infection of concern. Contrary to belief, tuberculosis over the last 3 years, what we have transplanted, so we have done close to around 260 thoracic transplants, and we have not seen that tuberculosis is a major problem. Only 17 of our patients have had tuberculosis, but Aspergillus is something which is really, really concerning in India. So most of our patients are on voriconazole prophylaxis for the first year, because our immunosuppressive goals are highest during the first year, as the episodes of acute rejections are highest during the first year. And after the first year, we drop in our goals, and then the infection rates also do come down. Now, rejection post lung transplant can be, of course, of two types, acute and chronic. Acute could be antibody mediated or cellular, and similarly chronic, or what we call as CLAD, that is chronic lung allograft dysfunction, can manifest as bronchiolitis obliterans syndrome or restrictive allograft syndrome, which is also called as RAS or RCLAD on some terminologies. What I want to say is that acute rejections are pretty amenable to treatment if they're caught early, if they're diagnosed early. The patient's immunosuppression just needs to be augmented for some time. And the mainstay of treatment for acute rejections revolve around IV corticosteroids, plasmapheresis, or thymoglobulin. whereas the chronic rejection is not so amenable to treatment. Despite the only way, there's been no definitive treatment which has been still found to be good to treat CLAD, and this is the reason why survival of lung transplantation, the median survival still hovers around 6.5 years. So this is what I earlier said, that on transplantation, the median time for people who are free from any kind of a lung allograft dysfunction is, if you look at it, it's close to around 6.5 years for the first transplant, which is represented in the blue line, and it is even lesser. So 50% is close to around 4 years when patients are retransplanted. In India, we have certain issues in India. One is, of course, we still are getting a lot of patients who are referred to transplant unit much late. By the time they reach the transplant unit, either they have become very deconditioned or sick for the transplant, or they have already started developing pulmonary arterial hypertension, which precludes a lot of these patients from getting a single lung transplant, particularly our elderly patients. Tuberculosis history. Now, because there's a lot of patients who have past history of tuberculosis, so it is a compelling indication to do double lung transplants only, so the waiting time also goes up a bit. As I said, our patients are very deconditioned. One of the things what we have noticed is that with the diagnosis of ILD or an advanced lung disease, patients tend to start limiting their physical activity, and they just start getting deconditioned. So before we can transplant these patients, we have to put them through an exercise or a pulmonary rehab program to recondition their body back before we can take. Cost is one real big factor in India at the moment. The transplant is costing around 35 lakhs, which is, we understand it's a huge cost, but I think as more and more centers start picking up lung transplantation, and the consumables and the disposables for lung transplantation start becoming cheaper, the cost of the procedure can be brought down. We do face a lot of issue with poor donor management, which allows us to use only around 10 to 12% of the organs which are donated to us. The couple of reasons that one, most of our patients, donors are road traffic accident victims, and they aspirate by the time they reach the hospital. In the ICU also, the lungs tend to get wet because most of the ICU teams are managing, they're more tuned to managing donors from perspective of liver and kidney harvesting rather than lung. But gradually, as more and more lung transplants is picking up, the donor management is improving, and we expect that it to improve further. And of course, there is lack of adequate donor data. We do not have any population-based HLA reports or HLA data available. So it's only when we have committed the patient to a transplant, we are halfway or nearly through the transplant, that we receive information about a cross-match positive. So we are just relying on the panel reactive antibodies. So people who have lower antibody levels pre-transplant, they do not. But at the moment, we are very, very skeptical of transplanting patients with high levels of antibody to the HLA, because they might be cross-match positive. It's not that we cannot do it, but it's a different protocol we have to run for these patients. Of course, this is something which is there. So there is an increasing demand for transplant. If you look at it, the waiting list numbers are going up across the globe. The number of transplants have also gone up, but what has remained absolutely stagnant is the number of donors. And this is, as I said, compounded by the low utilization rate of the donor lungs. We are able to use only 10 to 12% of the organs which are made available to us. So how do we increase the number of transplants? Of course, we increase the number of suitable donors by in vivo lung reconditioning, and something which we call as ex vivo lung perfusion. I'll just briefly touch about it. And of course, now it's time ripe enough that in India, we start looking at donation after cardiac death as well. At the moment, we only have NDD, that is donation after neural death, but now we have to start considering donation after circulatory death, which can be done in controlled environment in the ICUs. Every organ matters. This is what we call as the ex vivo lung perfusion. So lungs which are marginal. So we get these lungs and they are connected to the conventional ventilator and then to a circuit where a deoxygenator keeps on adding carbon dioxide to the circuit. The ventilator gives oxygen, and we can assess these lungs on this ex vivo for a period of 6 years. We can heal these lungs. So there are studies where antibiotics are run in this circuit where we can treat small patches of pneumonia. We can dehydrate these lungs if they become soggy and heavy because of fluid overload, and around 15% more lungs can be used by the use of this ex vivo perfusion. The only limiting factor is the cost, that running an organ on ex vivo costs somewhere around close to around 8 lakhs in India at the present scenarios, and this adds to the treatment cost. So just to summarize that lung transplant definitely is a treatment option for patients with advanced lung disease whom medical therapy has either failed or failed. But optimal candidate selection and timing of transplant is very, very important. The science of lung transplantation has improved and is constantly improving, and this is translating into better survival rates. And in India, we have our unique challenges, the answers to whom can only be found as we gain more and more experience on lung transplantation in India. Thank you very much for a very patient hearing. It's whenever you want to take questions, Dr. Pradyumn.
Yeah, it's a beautiful, extraordinary. What we thought, it is much beyond. And I request Dr. K K Pareek sir to take the questions and any discussions. Dr. Pareek sir.
Sir, unmute yourself. Sir, unmute yourself. Sir,
unmute करें सर, unmute करें.
आवाज नहीं आ रही सर. आवाज नहीं आ रही सर.
Volume here. Thank you, Dr. Vivek, for a very excellent presentation on a very recent topic. I think in future, the scope of lung transplant will increase with the increased number of cases of post-COVID lung fibrosis. If there are any questions from the house, anybody?
Dr. Vivek Singh, can I ask a question?
Sure, sir, sure.
Definitely, this is a new subject in post-COVID patients, fibrosis, because when we were student, we used to heard about the lobectomy in post-tubercular fibrosis and all other diseases, because lung transplant is a very expensive and definitely required a lot of things and post-transplant problems. So is there any study which is comparing between lobectomy versus lung transplant? That is the safest procedure, and of course, because survival rate is, I don't know which is the better procedure. Is there any comparison between lobectomy or isolated removal of the part of the lung with lung transplant in post-COVID fibrosis?
No, sir. There is, for the post-COVID fibrosis, no, because for COVID, the indications of lung transplant have been very, very clearly defined, that people who have continued to have persistent respiratory failure, even after 4 to 6 weeks of the initial onset of the respiratory failure, or who continue to be hooked onto life supports, despite being optimized on the medical therapy. Because I think lobectomy will not help these patients, because COVID is a very, very generalized involvement of the lungs. We are not getting a very localized involvement of the lung. So removing a part of the lung would not suffice at all. It will rather worsen the condition of the patient. Coming to your observation and your experience with about lobectomy in post-tubercular bronchiectasis or post-tubercular sequelae on the lungs, that could always be offered, because if tuberculosis was afflicting only a part of the lung, like maybe the right upper lobe or the right middle lobe, and the rest of the lungs are spared, we still advise our patients that, okay, fine, that's a better surgery to do, because it's a less risky surgery. It's a less extensive surgery rather than lung transplantation. So lung transplantation is only considered in patients who have end-stage respiratory failure and they're not amenable to any kind of a corrective surgery. If you recollect, even for emphysema, we say that for COPD emphysema, lung transplantation is only offered to patients who have homogeneous distribution of emphysema. That is, they are not amenable to any kind of a lung volume reduction surgery or bullectomy. It's such a homogeneous distribution. So if the disease is widespread between the two lungs, that no local resection can be done to improve the symptoms, then only lung transplantation.
Thank you, sir.
Dr. Vivek,
Yes, sir.
how many lung transplants have been done in post-COVID fibrosis in India these days?
So the data is still being collated, sir. Unluckily in India, the data is a little trickle to come. I can tell you experience of our center. So since August, when we started, we shifted from Chennai to Hyderabad, and it was only in August that the government allowed the organ donation back. Between March to August, there was no donation happening in the country. We have done 9 COVID transplants till now, post-COVID fibrosis, and these are the patients I'm talking about who had no lung diseases prior to this getting the COVID infection. And in these 9 patients, all of them had to be bridged through an ECMO because they were on ventilator with very high FiO2 in the native cities. Out of this 9, we have discharged 7. One patient we have lost because of infection, and one is recovering. He's off the ventilator and he's being mobilized. He's in the ward, due to be discharged in the next week or so. So that has been our experience about COVID. But I think what we have noticed in the last 3 or 4 months, which we have been transplanting, is that the initiation of ECMO support should be early. If the ventilator is not, if the lung is not settling on a conventional ventilation, within a week's time, we are not getting a reduction in the FiO2. Of course, proning can be attempted. But even after proning, we get the patient supine back and the FiO2s are going up. And even after 1 week, we are not able to move any headway on the ventilation. ECMO support should be considered. This lung should be rested, because what we are getting in a lot of patients and a lot of calls is pneumomediastinum and pneumothorax, because the lungs are being ventilated at high pressures. They're becoming very, very hard. And I can tell you from the pathology of the explanted lungs in these COVID patients, what we have seen is that there's a total destruction of the lung parenchymal architecture. It's becoming very, very hard. It's something like it's becoming muscular, where the expansion of the lungs is just going to go. So there are patchy areas of lungs which are very normal, and patchy areas totally there's destruction of the parenchyma. So coming to your yeah, sorry. You were saying something, sir.
No.
So the carry home, the message is we should not wait long and we should not start ventilation, but we should try to prefer to put the patient on ECMO for a better outcome.
Yes, I think 1 week of ventilation, no improvement, discussion should be done around ECMO and the lung should be rested.
So thank you, Dr. Vivek Singh. It's a wonderful information, and we are our heads off to you and doing for such a nice job and such a nice information you have delivered to us. So it's a time for Dr. Raja Dhar. We are getting late with the Dr. Raja Dhar. So I request Mr. Ajay to Dr. Raja Dhar ka program chalaye. We got a message. Thank you.
It gives me great pleasure to be here with you today. I would like to thank Dr. Pradyumn Sharma for inviting us to speak to you at this meeting today. I would like to introduce my colleague, Dr. Shubham Sharma, who is a consultant working at Fortis and subsequently in CMRI in the not so distant future. My name is Dr. Raja Dhar. I head the Department of Pulmonology at Fortis Hospital. And again, I look forward to working in CMRI in the not so distant future. We will discuss today about COVID. And you've heard discussions about COVID over the last 9 months in various forms and shapes. And to an extent, I know all of you are experts in this field. So what is it that we can add to this today? So as suggested by Dr. Sharma, we are going to use a slightly different format, the grand round format, where Shubham will be presenting a case a case which is real, but to an extent hypothetical, raises certain issues about COVID, which are questions for yourself and even questions for us. And between Shubham and myself, we plan to discuss these answers. We'll come up with clinical suggestions which you might find useful going into the tail end of the pandemic, hopefully. And then we'll end up taking questions from you, clarifying some of the questions that we might not have been able to answer. So Shubham, stage is all yours. We'll start off with the questions now.
Thank you, sir. I will be sharing the slides with you now, and we'll start with the case right away. I hope you can see the slides. Is it?
Not as yet, Shubham, but hopefully soon. It takes a little while, so I'm sure the slides will come up soon.
Right. I think it's visible now.
It is visible now.
Right. So good evening, friends. We'll right away go to the case. So here is a 49-year-old male who teleconsulted his general physician for anosmia and mild cough and generalized weakness for 3 days. He didn't give any history of fever, cough, or dyspnea or any abdominal symptoms. The patient is a healthcare worker and a radiological technician, to be very precise. He is a known case of diabetes mellitus and hypertension, which are both controlled. He denies any smoking history and denies any respiratory comorbidities. So you have a 49-year-old male, has anosmia, mild cough, and generalized weakness, and is a diabetic and hypertensive. The general physician advised him to review with a chest radiograph and monitor his symptoms and saturations, and also was advised to get an RT-PCR done for COVID along with the chest X-ray and follow up in another 2 days. So Dr. Dhar, this timing, what would you recommend to your patients, or what should general people be doing as after having these symptoms? Should they be waiting for 4 days, 5 days, 7 days since onset of symptoms, or should be getting a COVID test right away?
I mean, Shubham, if you look at the literature suggests that the viral replication is actually quite high, even early on in the disease course. Now, the problem is, what do you call symptoms? So this gentleman, for instance, you've described, has got very mild symptoms of COVID, at least when the disease has started. So anosmia, lack of taste, to me, is almost like asymptomatic disease. So if you look at onset of fever as being an indicator of viral replication, and if fever is the point of starting, you probably would start as early as possible. For this gentleman, where anosmia fatigue seems to be the most important symptom, I would probably wait 2 or 3 days. So about day 4 or day 5 from the onset of anosmia to get the test done in these individuals. So that's what I would do in clinical practice. In most cases, I would wait till about day 4 or day 5 from the onset of symptoms, where I believe the viral replication is the most or at maximum.
Would you say the same for patients who are diabetic, hypertensive, have multiple comorbidities, and
Sure.
Specifically for this patient who is also a healthcare worker and has been involved in doing chest X-rays and CT scans
Sure.
on a regular basis?
Sure. So valid question, good question, Shubham. So there are a couple of scenarios that you've described. First, we'll take the comorbidities question. So this guy had diabetes and hypertension. However, the comorbidities don't seem to indicate a greater viral replication. What it does actually prove is a poorer prognosis. So these patients end up having more of severe COVID rather than having a greater viral load. So answer to your first question, I don't think the comorbidities mandate that you do the test early. The second question, which is more thought-provoking, is the job of this guy. The fact that he is a radiology technician, the fact that he's probably had contact even earlier compared to when he presents with anosmia. So if you have a history of contact, and if you've got a defined history of contact, you would do it 4 to 5 days down the line from the history of contact. And you wouldn't think about the onset of symptoms in that case.
Right.
With a radiology technician, I think it'll be difficult to establish the time of contact. So again, with a mildly symptomatic guy, if this guy had fever of 104, I would probably say, please do the test immediately. And if required, we'll repeat a test 2 or 3 days down the line if the first test came back as being negative. However, with the mild symptoms he has, I would have no discomfort in waiting for a bit longer as long as this gentleman stayed in isolation.
Right. My next question to you is, this patient, since he's a healthcare worker, we keep talking about this guy because of his profession. So would you recommend any prophylaxis in such scenario? Is there any role of any prophylaxis once the patient has symptoms or even before the patient develops any symptoms in general for healthcare workers? Because that is the
Sure.
most common question for healthcare workers.
Sure. So, I mean, there is a role, but unfortunately, we haven't managed to find the right drug. So all the trials that have happened till date, be that with hydroxychloroquine or chloroquine, be that with ivermectin, or even the ongoing phase 2 trials with favipiravir, have not yielded a positive result. Neither have they yielded a positive result for pre-exposure prophylaxis, nor have they yielded a result for the more important post-exposure prophylaxis. So you've had a known contact. Even then, if you take the drug, it does not seem to work in these individuals, at least with hydroxychloroquine and ivermectin, the two drugs which are bandied the most and are a part of the state advisories in various parts of India. So often taking a prophylaxis gives you a placebo effect. It makes you feel better. So if you feel strongly as a healthcare worker, then take it. It will at least give you mental peace, if not anything else, and it might work. We don't know. Absence of evidence is no evidence. It's not the case. So you and I have not taken the drug. But however, I know of colleagues who have, and the colleagues who have had the disease in some cases, have not had the disease in some cases. So I think it depends on the comfort level. There's no evidence either way for use of prophylaxis in COVID-19 till date.
Right. So moving on, this patient was prescribed vitamin C, zinc, and vitamin D, and was advised to monitor symptoms and SpO2 and review SOS in case of worsening symptoms or dropping saturation. So he came back to the physician, was RT-PCR negative, and this was his X-ray, which was more or less normal. So my question to you is, the patient tested negative, is a healthcare worker, has comorbidities, probably had contact with a positive patient, and has some sort of typical symptoms related to COVID, especially given the current season, changing seasons. Many people are coming with the anosmia these days, and most of them might not have COVID. So such patients, should they be isolating or not? Especially given the fact that they have to work.
Yeah. So, I mean, important message for the audience, and I'm glad you asked this question, Shubham. So I think the message is isolate, isolate, and isolate in the middle of a pandemic. So even the smallest suggestion, be that in the form of anosmia, be that in the form of allergic rhinitis symptoms, be that in the form of sore throat, lack of taste. So even with your very mild and mild symptoms, I think it's best to isolate for a week. You don't have to get a test done. If you have no symptoms for a period of 1 week, in the pandemic, the current situation just now, you can probably go back to work again. If you have mild symptoms, you need to isolate for a total of 2 weeks. And that's most of the cases. But I think important point that you bring up, that even with mild symptoms or very mild symptoms, in the middle of a pandemic, it is important that people isolate and understand the importance of isolation.
Right.
I wanted to ask you a question.
Yeah.
So from your previous slide, so you know, you and I and plenty of other doctors, I guess, keep prescribing vitamin C, zinc, and vitamin D. My question is, why do you think we do that? And B, how long would you do it for in clinical practice? I think that's important for the audience too. So what do you think
So
would
there
be
is
your...
variable, sorry. So
Yeah,
there is
sure.
variable evidence, especially from previous studies regarding chest infections, including ARD, especially for vitamin C and vitamin D, including for TB. Again, just like we talked about the prophylaxis for patients who work with COVID, especially healthcare workers, no evidence is still evidence. We have some evidence that vitamin C and vitamin D have protective role in terms of boosting the immunity, including zinc. So that is why these are being prescribed. There are newer studies that recommend higher dose, very high dose of vitamin C, up to 20-24 grams a day. But again, the evidence is lacking. We have not seen any harm, and usually we prescribe it for 2 weeks as long as the patient is in isolation or is being treated. Again, over the top prescription of these medications, especially in cases where patients do not see physicians, taking a lot of vitamins can also lead to hypervitaminosis. So patients should always be in touch with physicians so that over the top prescription and excessive use of these medications should be avoided, as well as there is no harm in taking when given in moderated amounts.
Sure. So very, very good, but strong messages, Shubham. So A, there's lack of evidence either way, favor or against. Second, please do not give these drugs for too long. So Shubham says 2 weeks. You can do it up to 4 weeks, but please don't give it for longer than that. Third, these drugs are safe, but are not absolutely safe. So some amount of monitoring, some amount of thinking is necessary, even when you prescribe the vitamin C, the vitamin D, and the zinc in these individuals. Thanks, Shubham. So let's proceed.
The patient tested negative, like I showed you, the X-ray was absolutely clean. However, on 6th day, just 1 day after he tested negative, the patient developed a fever of 101.6 degree Fahrenheit and also complained of increasing cough, which was non-productive. Besides the symptoms that he had, those continued. And his saturations were 95-96% at room air. He was isolating at home. We did a repeat chest X-ray, and this was the chest X-ray at day 6. So this raised the suspicion of COVID. He was advised to repeat RT-PCR as expected. However, he tested negative again. So the patient was admitted on day 6, the same day, same evening, since the first symptom, first anosmia, and given the radiographic changes and persistent high-grade fever, he was recommended admission, and he was initiated on empirical antibiotics. Antibiotics because he tested twice negative. This was the CT thorax. It shows bilateral, multifocal, peripherally placed GGOs that we keep seeing in a lot of patients, now more commonly in patients with COVID. So Dr. Dhar, what would you recommend now? The patient, diabetic, hypertensive, rapidly progressive symptoms, high fever, has tested twice on RT-PCR for COVID, has tested negative, and has a CT like this and the X-ray that I showed. What would you recommend next? So my questions are, would you look for other causes, and what are those causes?
Sure. So we've faced this situation repeatedly during this pandemic. When I say repeatedly, it doesn't happen every day, but it probably happens once a week. These cases crop up once a week. And it's difficult because it can probably be one of two causes. We know for a fact that certain viruses or other atypical bugs, adenovirus being an example, viruses like rhino being an example, and even rarely mycoplasma can mimic findings that you see on this CT. So these are rare causes in the middle of a pandemic. Most cases, you would actually end up finding COVID-19 itself. However, it's good to look, because if you don't look, you don't find. And if you don't find, you cannot treat. So I think other viruses, atypical infections aside from viruses, would be high on my list of differential diagnosis here. So how do you find out? That was your other question. So I guess you would find out by doing a biofire sample, doing a ELISA-based assessment of the upper airway, a biofire assessment of the upper airway, which looks at atypical bugs, and it looks at other viruses that we talked about a little while ago. The other possibility, and we've seen that this again in quite a few cases, is that you don't have any virus in the upper airway, but you have all the virus in the lung. So the virus in some way, 5-6 days down the line, has made its way downwards into the lung, and hence you find no virus or very little virus in the upper airway, which is why your RT-PCR keeps coming back as being negative when you use a nasopharyngeal swab. However, if you sample the lower airway, as in you did a BAL in these individuals, you would find that the COVID test is being positive. The RT-PCR test on BAL is being positive in a large majority of these cases. Now the question arises, there's a lot of controversy about doing BAL in these situations. So Shubham, you've done quite a lot of BALs in these patients. What's your take, both from a patient perspective and from a healthcare worker perspective, about the hazards of BAL in scenarios like this?
So, sir, we have been seeing a lot of COVID more these days. instead of other viruses. We have hardly seen other viruses and atypical infections in the current pandemic that's ongoing. So doing a bronchoscopy is necessary sometimes because a patient is worsening, is at the borderline, his oxygen levels are 92-93% on room air, he's probably rapidly worsening, and you would not treat the patient with empirical antivirals, which would have been my next question, because there's no guideline and that's not recommended as of now. Like it was recommended in the older days for tuberculosis based on radiographical changes, giving a patient empirical ATD, which is not recommended right now for COVID empirical antivirals. So doing a BAL adds to the value because that gives you an early diagnosis instead of waiting for a person to worsen and having no evidence of COVID. You should do a BAL early if you have tested RT-PCR negative on 2 occasions specifically. However, there are shortcomings to that. That increases because BAL increases the amount of exposure to aerosol for the healthcare workers. It is a risky affair. So the number of people in the bronchoscopy unit should be minimized. The healthcare workers, doctor, and the nurse accompanying or the technician accompanying the doctor should be wearing the N95 respirator, should be properly covered with the PPE. That's the minimum requirement. The recommendations are to use the disposable bronchoscope. However, given the fact that it's not available easily everywhere, the scope that you have available should be used, but it should be well sterilized before and after the procedure. Ideally, it should be sterilized for 24 hours post-procedure. And the room that the bronchoscopy is being done in should not be used for another patient, especially if another bronchoscopy is required. And try to do this bronchoscopy at the end of the list if you have multiple procedures on the list.
Sure. And a negative pressure room if that's available, isn't it, for doing the bronchoscopy if possible. So all topics covered. So just to add to what Shubham said. So Shubham said rightly that empirical antivirals are not recommended. And the reason it's not recommended is because you would land up with an occasional patient where the lavage does not yield COVID-19. And you understand that the sensitivity of a BAL is the highest out of all tests that you can do for isolation of COVID in the 9 months that we have actually seen this virus. It's definitely the test which gives you the highest sensitivity as far as RT-PCR is concerned. So imagine that you have the reassurance of just continuing the remdesivir empirically and you end up with maybe a mycoplasma or even a secondary infection, for instance, which you might miss. So when you do a BAL, you're not just going to send a COVID, you're going to send culture sensitivity, and you might have a secondary infection, which also gets isolated. So we feel as a team, and there's lots of other people who feel the same, that you need to take precautions for the healthcare worker when you do a BAL. But a COVID-19 infection or the suspicion of a COVID-19 infection is definitely not a contraindication for doing a BAL, as long as I say it again, as long as you take adequate precautions. Back to you, Shubham.
So, like suggested by you, sir, we did the BioFire upper respiratory tract panel to look for other viruses, and this patient tested negative for all of them. And so we went ahead with the bronchoscopy. The BAL was positive. So we went ahead with the bronchoscopy because by the 8th day since his first symptom, the patient was having fever and was not responding to IV antibiotics. So we were pretty sure that he probably has COVID infection, but we needed evidence, or we wanted to rule out secondary infections that were not responding to the IV antibiotics that we started. So we went ahead with the BAL. And BAL was positive for COVID-19 on the RT-PCR. And after that, we sent the initial investigations, and the D-dimer was 1300, IL-6 was 25.20 with a cutoff of 7, the normal being less than 7. So what are the treatment options? The patient has comorbidities as a healthcare worker, has high fever, has significant changes on the CT scan and the radiograph. So what would you treat him with? He's still not hypoxic. He's still in the moderate category of the disease. based on his oxygen requirement, but not on the basis of his CT scan, how would you treat this patient? Would you give him ivermectin with doxycycline, which a lot of physician friends are doing? Would you give him favipiravir, or would you give him remdesivir? Or would you just treat him with supportive drugs, as there is no very significant evidence for above drugs, especially given the fact that now WHO has given a negative recommendation, or does not recommend remdesivir, especially for severe disease. So what would you do?
So Shubham, let's think about this a little bit broadly. Let's think about this specific case. So you said it's day 8 of illness and the patient continues to have fever. So at day 8, so post the magic day 7, you probably move into the zone where patients are at the risk of a cytokine storm. Not everyone gets it, but if you get it, it's in the 7 to 14 day window where you might get it. And we often presume that the only symptom that you have because of the cytokine storm is breathlessness and hypoxia on a monitor. That's not the case, as a lot of you know. You can also have fever, persistent fever, or a recurrence of fever as a part of the cytokine storm. So the first thing to say is that do not presume this is an infection. It might be an infection. It might be the onset of a cytokine storm. If it's an infection, it could be the tail end of the virus. So you know the virus continues to replicate from up to 10 to 14 days. That's the maximum time period that it replicates. In most cases, it wouldn't replicate after that. Or, like you said, it could be a secondary infection. So I think you need to think secondary infection, you need to think the virus, and you need to think, is this a cytokine storm? In which case, even without the hypoxia, we have thought about using steroids in these patients post day 7 when the fever is persisting. Now, so obviously you need to cover all eventualities, and there are investigations and indicators to lead you in the right way. And I'm sure Shubham will get us back to those biomarkers in a few minutes. So let's stick to the question that you're asking at the moment, Shubham. So what treatment option? So I think for a disease which is viral mediated, I would use a drug which is an antiviral medication rather than using a drug which is aimed at reducing worms, but also has an antiviral effect along with it. So that's the first thing to say. So even without evidence, my take would be use an antiviral rather than using an antihelminth, which has antiviral properties along with it. So that automatically excludes ivermectin and doxy in this patient for me. Now, if you look at trials for COVID-19, the evidence for both antivirals, favipiravir or remdesivir, is shaky. There are a few positive trials. There are equally some well-done negative trials. For me, the drug favipiravir works in people who are at home and have mild disease or very mild disease, and works early during the onset of disease. For a patient who is admitted in hospital, for a patient who continues to have fever, for a patient who has got severe CT changes, so CT severity score of more than 14, my first choice by far would be remdesivir. And while the trials might not always indicate it, I think remdesivir is a more potent antiviral against COVID-19 as compared to what favipiravir is. And I wouldn't dare not give any drugs to someone who's unwell a day 8 of COVID-19 infection. So I think the last option for me goes out of the window straight away.
So like you said, sir, the reason, in my opinion, behind a lot of negative trials for remdesivir is that remdesivir has been tried in patients where viral replication has probably almost stopped by the time it has been used. It has been used for more severe disease, and probably there is no more viral replication happening by then. And it's usually the cytokine storm or post-COVID effects on the lungs that the patients usually suffer with, and hence the negative results. So moving forward.
So Shubham, just taking forward what you said, I think important to understand that all COVID drugs only work when you use them early. I think that's the clear message that we have got. So if you use a drug on a patient with COVID who's on a ventilator, for instance, almost nothing works. Most of these patients would die, and the ones who get saved are probably more due to providence rather than the expertise of treatment that we have. So I think important point for people, the audience, what Dr. Shubham Sharma just now said, don't use these drugs as a last resort. Use them when the patient is getting sicker. Use at the start of hypoxia. Use it when the patient has a recurrent fever or persistent fever beyond day 7, rather than waiting till the time the patient ends up on a ventilator.
So we started him on remdesivir. We also gave him low molecular weight heparin and also continued bronchodilators, vitamin C, zinc, and vitamin D. The patient started feeling better. However, he continued to have fever, 99 degree Fahrenheit. We started with fever up to 102 degree Fahrenheit. The severity of the fever came down. The patient started feeling better, a little more energetic than before. However, the fever continued. So what would you recommend in a patient like this who is continuing to have fever post starting of remdesivir 48 hours down the line? What would you change?
So it depends on how the parameters are. So I think here your biomarkers come in useful, Shubham. So I think if this patient has persistent fever and new opacities on chest X-ray, you would think secondary infection. If you had a rise in total count, if you had a rise in CRP, if you had a rise in procalcitonin, you would feel that this patient probably has a secondary infection again. And you would think of getting a respiratory sample, or you would think of escalating the IV antibiotics that you're giving to this person. If this patient has a low procalcitonin and you feel that the patient is not getting any better, actually getting worse, you worry about a cytokine storm in these individuals. And while the patient still has no hypoxia, you try and preempt hypoxia by thinking about steroids. You might want to get an IL-6 done in these patients at this stage to find out whether with a low procal, you have a raised IL-6 or not. And why do I say that? I say that because even a secondary infection can cause a very sharp rise in IL-6. So IL-6 is an inflammatory marker. It's not a marker for COVID-19. So low procal, high IL-6, you think this might be a cytokine storm. High procal, high IL-6, you think that this is likely to be a secondary infection, which is causing a rise in IL-6. And hence these two biomarkers need to be balanced. They need to be checked together rather than being looked at in isolation.
Right. So we started him on IV corticosteroids because given the fact that his initial procal was low, his IL-6 was 25, almost 25. And the patient responded wonderfully to steroid. We started him on dexamethasone 8 mg IV OD. The fever subsided within 24 hours, but now the patient started desaturating up to 86-87% on room air and required up to 1 to 2 liters per minute of oxygen. We started him on awake proning. The patient improves, but the desaturation continues. He desaturates on walking. However, when he is lying prone, he is on room air and maintaining saturations well above 95%. So why would this patient desaturate is the question. You want to go ahead, sir?
So before that, so a couple of things, Shubham. So you do this, but I have a question for you. So you've had a lot of experience in proning. So tell the audience today as to how important you feel proning is. Is it beneficial only when the patient is prone? Or do you think you've seen patients who've actually got better in the long term, where the COVID treatment and awake proning being used as an adjunct actually help in patients' recovery in the long term? And then you can tell us about the importance of getting COVID-19 patients to walk. You know, it's been a challenge in this pandemic to get healthcare workers to go near patients in the first place, let alone getting them to walk. So if you talk to the audience about how important it is to check whether the patient desaturates when they walk or not, and how you go about doing that, I think it's a strong message that goes out to people who are listening to us today.
So to answer your first question, sir, awake proning has a big role. So we have been proning patients in the past, especially in ARDS, patients who were ventilated. But given the lack of ventilators, we started proning patients early in the pandemic, even when they were not ventilated. So we have found out in the long term that the patients, especially with basal consolidation, tend to have hypoxia because of poor oxygen penetration in those areas. Proning helps them in improving the oxygenation of those areas. And besides that, what is more important is it reduces patient self-induced lung injury, which we have started noticing in a lot of patients, especially the awake ones, that patients tend to be tachypneic, especially people who are moderately hypoxic, they do not complain a lot about their breathlessness. But when you see the patient will be tachypneic, and that diaphragmatic movement, because of the tachypnea, causes a lot more damage to the lung parenchyma, and that increases the worsening in terms of parenchymal environment, and increases the tendency for lung scarring and fibrosis in the long term. So proning actually helps in those aspects, especially in the long term, along with the short-term improvements in oxygen saturation levels. Now, why would the patient desaturate? There could be multiple reasons. One is that the patient has a lot of consolidation, and the ventilation perfusion mismatch caused by the consolidation causes a lot of desaturation, especially on walking, because the demand of oxygen increases in the lung. However, the lung parenchyma left for ventilation, actual parenchyma, is less compared to a normal lung. The other reason could be microthrombi. COVID, being a prothrombotic disease, can lead to a lot of microthrombi in the smaller vessels. We have not seen a lot of large pulmonary emboli happening to COVID patients. However, we have seen subsegmental emboli happening in these patients. So that is one reason the people, especially physicians and pulmonary physicians, should be seeing their patients after they walk. The oxygen levels at rest are important. However, patients should always be walked every day, once during the morning rounds at least, to see if the patient desaturates or not, because that has longer term implications. If the patient is treated early for these complications, especially the thrombi, then the outcomes are better. And in the long term, if the patient is prescribed maybe low molecular weight heparin or Novax in the long term, the outcomes improve, and you can actually reduce the chances of pulmonary emboli based on a D-dimer value.
Sure. So VQ mismatch due to consolidation, you said, and you spoke about microemboli. I wanted to ask you a more philosophical question, Shubham. So you're a young, dynamic pulmonologist. Have you felt afraid? A lot of your colleagues have actually felt afraid of walking with patients. Would you leave it to a nurse to do it? Would you do it yourself? How do you feel when you walk these patients who might be infected, who might have a high viral load and the risk of transmitting infections?
So honestly speaking, if a nurse can do it, if a physiotherapist can do it, why can't a doctor do it? There's no harm in doing that as long as you are well protected. Ask your patient to wear a mask. You are donning a PPE. As long as you do that, you are safe. I have been safe for all these 8 to 10 months, and I intend to be safe for the remaining days during COVID. And I think this improves patient outcomes. This gives you a sense of satisfaction, and this gives you a sense that the patient, when he gets better, would go home and would not come back in the emergency with worsening saturation, because you might have missed something because you didn't walk the patient in the morning rounds. So that is what my opinion is.
Yeah. And to add to that, Shubham, agreed with all of what you said. And to add to that, your patient feels far more confident, isn't it? If your doctor walks with the patient feels secure in the knowledge that he's not being pushed to the corner and being avoided like is happening throughout the pandemic. It gives the patient a lot of confidence that he's being well looked after. So point well taken. Let's move on. Yeah.
COVID patients tend to become very anxious, and because naturally this is a disease that the entire world is anxious about. And if they have a sense of confidence, they breathe better, they're less anxiety-related tachypnea and less injury to the lungs. So moving forward, the patient was resaturating. We did a repeat prognostic markers. D-dimer was okay. IL-6 was not very significantly changed. However, his NT-proBNP was raised. We ruled out a secondary infection because his procalcitonin was well within normal limits. His echocardiography, after seeing the NT-proBNP, we did that, showed grade 2 LVDD. He was a hypertensive, and his NT-proBNP was raised, along with moderately raised IL-6. So what would you do first, sir? Would you diurese the patient, or would you think that the patient has cytokine storm-related hypoxia, or would you do both? Would you treat both?
So again, let me take a slightly broader view. I think this is very important. So let's talk about what you think about when a patient becomes more hypoxic at day 7 or day 8 of infection, which is something that we can encounter quite often in the severe COVID basket of disease. So In my book, if a patient worsens at day 7, day 8, highest on my list of differentials would be a cytokine storm. That's not because it's the commonest. It might be the commonest. However, what is more important is that it's the biggest killer we have amongst all the causes. So that's number 1 in my list. The second disease in my list would be a secondary infection. Again, a secondary infection at day 7 to day 10 is something that we have seen, especially when the patients are in intensive care and acutely unwell in hospital. So that's the time when the GNBs come in, the gram-negative bacilli come in, and hence it's important to think of it and look for a new opacity on chest X-ray, look at the procal, look at the CRP, etc. So that's number 2. Number 3 is definitely thromboembolic disease. And I think Shubham talked very succinctly, very clearly about small emboli, which are difficult to pick up on a CTPA. But if you look long and hard, you would find them. And the D dimer suddenly increasing or the D dimer being high at the start might direct you in the right direction. You might, if you have access, do an echo in these patients, and you might see a right ventricular strain pattern. You might see the right heart pressures going up in these individuals, which drive you in that direction. And a therapeutic low molecular weight heparin is what you would do in these individuals. Some trials are on with low dose thrombolysis, but I've not been convinced that this is the way forward in the long term in these individuals. So that's number 3. So we've said cytokine storm, we've said secondary infection, we've said thromboembolic disease. The fourth one is what we are talking about now, which is affection of the heart by COVID, the so-called COVID myocarditis. So what is this entity? So you could have right heart dysfunction, you could have left heart dysfunction, you could have biventricular dysfunction with COVID. These patients are by nature tachycardic. You might see some non-specific ST changes in these individuals, but the ECG might not show anything other than sinus tachycardia. A few of these patients might actually become bradycardic. And then it becomes a challenge because the antivirals that you give, especially remdesivir, might actually in some individuals also cause bradycardia. So think before you act, because you cannot stop the remdesivir in most of these people. That's a life-saving drug in your armamentarium. So think COVID myocarditis, get an ECG done, get a troponin done, get an echo repeated if you find that this is the new finding. And like you said, Shubham, you would want to diurese these individuals with diastolic dysfunction and a raised NT-proBNP, maintain a negative balance of 300 to 500 ml, make sure you check the inferior vena cava on a regular basis if you have access to an ultrasound or an echo machine, and make sure you have the right sort of collapsibility in these individuals to make sure that the fluid balance is right. So that's my take. There are other causes. There's the pneumothoraces that we won't speak about today, which can also make you hypoxic. But in my mind, those 4 causes, cytokine storm, secondary infection, thromboembolic disease, heart failure due to diastolic dysfunction, are the 4 most important causes of hypoxia at day 7 to 10 of COVID infections.
We discussed about all of this. We ruled out a secondary infection. We diuresed the patient. Since his IL-6 was not very significantly increased since the previous one, we didn't go for tocilizumab. What is your take on increasing the steroids now? The patient is on 8 mg IV OD of dexamethasone. What do you increase the steroids?
So again, there is no evidence, Shubham. So what we speak about now is, you can call it expert evidence rather than calling it true evidence. So there are 2 things that we have tried in patients who are way beyond day 10 and are desaturating. So one approach is thinking that these patients might have organizing pneumonia. They might have a more fibrotic picture in the lung, and seeing whether there's predominant GGOs, predominant areas of organizing pneumonia on CT, and hiking up the dose of steroids. Hiking up the dose of steroids increases your risk of infection. So strict monitoring of both the radiology, the chest X-ray, and the CRP and procalcitonin is very important when you hike up on the dose of steroids. The same thing stands true from a tocilizumab perspective. So we said cytokine storm is equal to high IL-6. And in my book, a high IL-6 would be well above 30, where the normal is less than 7, and a low procalcitonin. And there, if you feel that the patient is not ventilated, does not have the chance of going onto the ventilator immediately, tocilizumab is a drug that you can use. The risk, again, like steroids, even greater than steroids, to be honest, is the risk of infections. And we have seen patients getting fungal septicemia, getting fungal lung disease, getting TB, etc., with the use of tocilizumab when it's given late in the disease onset, especially when given to patients who are on a ventilator.
Right. So we diuresed the patient with Lasix infusion. He started improving. There was no desaturation on walking, and we were more or less convinced that this was just a fluid overload that we were dealing with. We didn't go on with increasing the steroids. And day 14, this was the day 14 of illness. His D dimer came down, which was already in the normal limits. His IL-6 also started coming down. You would expect another cytokine storm by this time, day 14. However, his IL-6 was low, so we were pretty much happy with that. And his NT-proBNP also came down along with his clinical improvement. Patient continued to improve slowly. So what is your take on discharge now? And would you do another COVID test specifically in this scenario, given the fact that this patient tested positive on a BAL rather than a nasopharyngeal swab? Or would you do another bronchoscopy?
So quickly, I think we have just about run out of time. We need a little bit of time for discussion. So discharge, if the patient is asymptomatic for 3 days with normal saturations, and even when you're walking them, the saturations remain stable, I would be happy about discharge. That's number one. No further COVID test would be my very strong message, because as all of you know, you can have dead virus lying around and still have a positive COVID test. And if you have a positive COVID test, you are legally obliged to ask the patient to isolate again for at least 7 days or even 14, according to some state rules, before they go out in the community. Are they safe around family? As long as they isolate for a period of 7 days or reach 21 days from the onset of disease. So onset of disease rather than the first COVID test, 21 days from then, it's safe for the family to be around them post 21 days or post 7 days after discharge, whichever is later. And infective for how long? So that's $1 million question. But we don't think people are generally infective after 21 days, which is why we put 21 days at the moment. We've actually traveled away here. So we started with 14, then we said 17, now we say 21. There might be a small minority who might be infected even after day 21. We don't know, but we take that chance and we let people live their life post 3 weeks, I guess.
Right. So without wasting time, I would just tell what we did with the patient. We discharged the patient without further COVID test, especially given the fact that he tested positive on BAL. We advised pulmonary rehab, breathing exercises, incentive spirometry. We did not prescribe him antifibrotics as yet because he was better and was improving. There's no role of antifibrotics in such scenario. And there were no long-term steroids given, again, because he was not hypoxic. We discharged him with an advice to get an early CT done on follow-up on OPD basis. Maybe 4 weeks, 4 to 6 weeks down the line is when the physician should be doing that. And we usually review the patients early post-discharge, maybe 10 to 12 days, 10 to 14 days after discharge, especially people who recover from a severe disease. Patients with mild to moderate disease can be reviewed a little later in the course of the disease or in the course of recovery. So that's what we did. And this was the CT scan of the patient at 4 weeks. So what would you do, Dr. Dhar? Would you advise steroids now or antifibrotics, or just follow up again at 6 weeks and repeat a CT, given the fact that this patient is doing good, is improving, his oxygen saturations are 96 to 97 on room air, there's not desaturation on walking. So what would you do given this CT?
Sure. So like you said, Shubham, it depends on the clinical scenario. In the clinical scenario that you've described and the CT that I see, the cuts that I see in front of me, basically show lots of GGOs, but nothing else which is significant. So when I say nothing else which is significant, I mean there's no fibrosis. And when I talk about fibrosis, I mean traction bronchiectasis. So in this patient who has got normal saturations at rest and even on mobility, on mobilizing, I would do nothing, no steroids, no antifibrotics. The situation would be different if clinically the patient is hypoxic, either at rest or when they are mobilizing. And the situation would be different if I found traction bronchiectasis on a CT. I think antifibrotics or steroids or both would be the way forward in this scenario. And we can take that up during discussion if the audience want to discuss about post-COVID fibrosis.
Right. So that's everything regarding this case. I think rest of the questions can be taken up in the discussion from audience questions. Thank you, Dr. Dhar. We'll end this presentation right away. Yeah.
Thanks, Shubham. So let's take some questions now. If you can put the questions in the chat box, and we'll discuss the questions for the next 15 minutes before we end the session. I look forward to lots of questions.
Thank you, Dr. Raja Dhar. Beautiful clinical presentation. Beautiful, heads off. And so many beautiful tips. So one of the reason I could not understand in dexamethasone, the Liberty trial and the NIH trial and Solid trial, they have used 6 milligrams of dexamethasone, but you prefer to use 8 milligrams of dexamethasone. Any point of difference?
No point of difference, Dr. Sharma. I mean, I don't think that this was a reasonably big chap. I think you go by body weight to an extent, but you're right. I mean, there is a number. So we've actually used dexamethasone less in the COVID pandemic. We have used methylpred more because we are actually more comfortable using methylpred. And we would normally use something between 0.5 to 1 milligram per kg of methylpred when we prescribe it. Dexamethasone, we would use anywhere between 4 to 8 milligrams, depending on the body weight of the individual. This was a heavier patient, so we went for 8. But I don't think I would crib if someone used 6 instead.
There's another point at the discharge. Many of the doctors, they write extended thrombolysis for another 10 days or 21 days, extended thrombolysis. So how do you take a message on this, on the post-discharge? At the time of discharge, would you like to put a NOAX or otherwise no drug?
So I don't think you mean thrombolysis, Dr. Sharma. I think you probably mean thromboprophylaxis. Yeah. So, so I would use thromboprophylaxis in 3 or 4 different scenarios. So I would use thromboprophylaxis in patients who have severe COVID and at the time of discharge are oxygen dependent and have a D-dimer which is above 1000, right? So that's one group of patients where I would send the patient home on apixaban 2.5 milligram twice a day. And I'll come back to why apixaban and why not the others in a minute. The second group of patients I would use it in is if in a patient who's had severe COVID pneumonia, you have a rising D-dimer and the D-dimer absolute value is above 2000. Even without the hypoxia, I would send them home on thromboprophylaxis at the dose that I mentioned a little while ago. The third group of patients obviously are patients who have been discovered to have clots, even segmental emboli on a CTPA done during stay during the hospital. I would do not thromboprophylaxis, but I would anticoagulate them like you would do in a pulmonary embolism patient for a period of 3 months, as has been recommended by various guidelines. So that's the third group of patients. So those are my sort of guidances. I would do it for where it's thromboprophylaxis. I would do 2 to 6 weeks, depending on the quotient of suspicion that I have. And echo helps before you stop, because you can look at the pulmonary artery systolic pressure and whether it's significantly high at the time of stopping or not.
Dr. Dhar, I have a question. In HRCT positive but RT-PCR negative cases, you said you will not use antiviral remdesivir, but will go for bronchoscopic and then RT-PCR positive. But in many institutions, bronchoscopy is not available. So is it not prudent to go for remdesivir on the clinical basis?
So you could do, Dr. Mathur, if you don't have access to bronchoscopy, or if you don't have a bronchoscopist who's willing to do a bronchoscopy in this scenario, and there are many, and I cannot fault them. It's a risky procedure for the healthcare worker during the pandemic. You take a call and you can give them an antiviral. The problem, like I said, is in a very small percentage of patients, you might actually have mimics of COVID-19. So the adenovirus, actually the CT mimics COVID-19 exactly. And we found 2 patients, well, 2 out of a lot of patients, 2 out of 1,000 patients who've actually had adeno and no COVID-19 on a BAL. So if you look at the guidelines anywhere in the world, there isn't even one guidance which talks about giving an antiviral without an RT-PCR test. There isn't any studies which have looked at it. And our clinical scenario, if you don't have access to a BAL, the best you can do is to base it on a CT and give it on the basis of a CT. I agree with you. We have access to BAL, we do it. And I'll tell you, we have about 36 patients and counting, where 2 RT-PCR nasopharyngeal swabs were negative and the BAL was positive for COVID. There were 5 in whom we thought that the CT looked exactly like COVID-19, but it turned out to be something different. In 4 cases, a viral illness, which was different. In 1, it was mycoplasma, which we discovered. So it can happen. I mean, you will miss a few cases, but I guess if you don't have access to BAL, you treat them with your antiviral, even without an RT-PCR test.
And in your opinion, what are the incidence of false negative RT-PCR?
False negative is about 25%, Dr. Mathur. So if you looked at 4 patients, out of 4, 1 patient would have a false negative test. So it's a significant negative test. For a BAL, the sensitivity is much greater. It's 93, 94%. So your false negative is only about 5 to 6%. It's actually the most sensitive test that's available for COVID-19. I'm not recommending everyone has a BAL. I'm just saying it's the most sensitive test that we have out of all tests that are available to us.
Sir, regarding proning, the word is a proning and awake proning, and how long, how many hours proning, and how many hours, and then again my patient deprone, prone, deprone, what could be the cycle? Because the things are not very clear. Some people
Sure.
16 hours,
So,
4 hours.
So
Proning.
Pradyumnaji, valid point. You know, when you look at patients being proned on a mechanical ventilator, there is much greater clarity because there's good quality studies which are available for it. And there it's at least 16 hours of proning in a 24-hour period. Awake proning has been used in the pediatric population and also in the mild to moderate ARDS perspective in small trials in the past. That's the only data we have about awake proning. In COVID-19, we have found more by accident rather than by design that people's hypoxia seem to be getting corrected early on in the disease process when you prone them. The longer you prone them, the greater the effect lasts when you make them supine again. So there isn't a formula. It depends on how compliant your patient is, how uncomfortable your patient is with proning, and how much they're willing to do. In an ideal world, you would want to prone them for an 8 to 12-hour period out of 24, and you wouldn't want to prone them for more than 2 hours at one go because that would be uncomfortable for them. So it's probably going to be 2 hours on proning, 1.5 hours off proning, then proning again, but there isn't a formula. And I suggest if you want to use it in clinical practice, you encourage the patient to lie prone for as long as they can, and then get them supine again when they feel uncomfortable, but encourage them to go back to proning again once they are good with it. It's difficult with obese people with a big tummy. You know, if you have a big tummy, to actually prone people and get them to lie prone is a challenge. It's only in patients who are reasonably sort of overweight and not obese or of normal BMI that proning is really possible.
So do you mean that the proning, normally it is said that once you prone a patient, it takes another 30 minutes to start the effects. And once you do for 2 hours or 3 hours, the effects last for...
I don't agree with that. So in real life, we've done a lot of proning, like Shubham was saying a little while ago, Dr. Sharma, and I have seen people responding magically to proning. 5 minutes. You talk about half an hour, 5 minutes, the saturations would go up by 7 to 8% in some individuals. It doesn't happen in all of them. In some people, the saturations actually go down after proning, but that's the minority. In a majority, you would see some effect. In some, again, a minority, but in some, there's a dramatic effect, and it happens almost immediately after you prone the patients. So my experience with proning personally has been brilliant. I think it's a brilliant tool in clinical practice. And even after COVID, and hopefully it's not long before it's after COVID, but even after COVID in my ARDS patients, it's something that I plan to continue doing and see whether it's got an effect in the non-COVID population also.
In proning, do you put a pillow on?
Yeah, so yeah, that's a good question. So what we do is we support. So the first time around, you have to do, it's like putting on the non-invasive ventilation mask for the first time, the BiPAP mask or the NIC mask. You stand with the patient, you put a pillow underneath the tummy, right? and you roll the patient over. You make sure that the arms are like that by the side of the pillow. I don't know whether you can see my arms or not, but the patient is lying prone. The arm is by the side. You put a pillow underneath the head on the side, and you put a pillow underneath the tummy so that the tummy is supported. It's not all squashed on the bed. And then you can, if you have a third pillow, and not all hospitals have that luxury, but if you happen to have a third pillow, you put it between the leg of the patient, the two legs of the patient, and then the patient can lie comfortably. Interestingly, I found out there's a few people who actually sleep that way even normally. They sleep on their tummy. So for them, it's easy, but that's a minority of people. Otherwise, you have to stand with the patient the first time around for 5 or 10 minutes and ensure that they lie in that position. The first few minutes, like everything else, is uncomfortable. But once you have soothed their nerves, you have reassured them, they normally manage well in majority. Some wouldn't, but in a majority, they do.
Dr. Dhar, what is the most appropriate time to start steroids?
Yeah, that's a great question. So I'll tell you what my take is on steroids. So in my head, I have got a protocol for steroids. So I would start steroids in anyone admitted to hospital where the saturations are less than 94%. I would also start steroids in people if they desaturate by more than 4% on walking a distance of more than 20 to 30 meters. So I would walk them. I try and walk all my patients. Patients were capable of walking, of course. I would walk them. And if they desaturate by more than 4%, I would start them on steroids. That's my indication number 2. My indication number 3 is that if post day 7, a patient continues to have fever of a reasonable grade, so 100 or more than that, or has a recurrent fever after day 7, I think this is a signal for a cytokine storm, and I would start a steroid in that population, especially if the CRP is more than 20 in that population of patients. So that's my third indication. The fourth and my weakest indication is, so when I say weakest, I mean I think the data is the weakest for it, is in patients where the CT shows organizing pneumonia-like pictures. Everything else is all right. The CT shows picture like organizing pneumonia. There I would discuss about starting steroids. I wouldn't do it in all of them, but I would do it in some of them. So hypoxia at rest, hypoxia on walking or desaturation by more than 4% on walking, post day 7 fever or recurrence of fever, especially with a raised CRP of above 20, and a weak evidence of giving up steroids in patients who have an organizing pneumonia picture on CT would be my indications for starting steroids in COVID-19.
Excellent. Thank you, Dr.
Am I audible?
Yes, sir.
Yes, sir.
Eh?
Yes, Dr.
Am I
Pareek.
audible?
Yes, sir.
Yes, Dr. Dhar.
Loud and clear, Dr. Pareek.
Yes. Wonderful deliberation. I think you have answered almost everything which is coming in physician's mind. But I just want to ask you, because we know that after 7 days or 10 days after the onset of disease, patient does not remain infective, and one may not ask for second RT-PCR, because after 10 days he becomes non-infective. So, but you said it is after 21 days. So what is the correct thing?
So that's a good question, Dr. Pareek. So like you said, if you look at UK, they have started letting people out of isolation after day 10 of being infected. So day 10 of having the first symptoms. In India, we have gone the other way. We have gone from day 14 to day 17 to day 21. So this is because the AIMS group came up with this suggestion of super spreaders in about 5% of the population, people who seem to remain infective for a longer period of time. And they reported one case which was infective till day 35, but a few cases who were positive beyond day 14 or day 15. So it depends on, like everything else in COVID, it depends on the balance between economics and safety and health, right? So for the UK now to get started and get people up and running, doing things is a greater priority as compared to isolating, because they think they've got the vaccine and they feel that this is a community disease and they probably have moved towards herd immunity anyway. With our vast population, we want to be safe rather than being sorry. And for us, a 5% population is actually a very big population. It's probably like the population of Ireland, if not the population of the UK. So for us, you are on the side of caution. Most of the patients, like you said, would become negative, would become non-effective by day 10. But the logic is, it's most cases, not all of them, and not all of them is still a significant percentage, which is why you go till day 21 and you play it safe rather than allowing people to go at 10 days. I think once the vaccine becomes available in India freely and people have started getting vaccinated, our number of days for isolation will also come down towards 10. But that's going into the future because we have not got anywhere near herd immunity as yet.
Thank you. One thing more I would like to ask you. You
Sure.
said use of remdesivir. Now, what is the right indication to use remdesivir, whether it is a hypoxia or it is a temperature or day of onset? Even if you want to use it, just thinking that it may, even in a COVID negative, do you say that we can inject remdesivir, or you can use remdesivir?
So I'll tell you, like I
Yes.
did with the steroid question that Dr. Mathur asked me. So I'll
Yes.
give you a similar answer. My indications for giving remdesivir to people, right? So I would give remdesivir to only patients who are hospitalized. There are some people, I say this because there are colleagues of mine in Maharashtra who would give remdesivir at home.
Yes.
So I wouldn't do that in dream, let alone in real life.
Yes.
That's number one. Second is, if my patient has high spikes of fever beyond day 3, day 4 of onset of symptoms, and the patient is in hospital, I would give them an antiviral which is more potent. And in my book, remdesivir is a more potent antiviral as compared to favipiravir. So I would opt for favipiravir. So that's my moderate disease indication of giving the drug. The third indication, and this is actually from the literature, is that patients who have GI COVID, patients who have significant gastrointestinal symptoms, the spasmodic abdominal pain, the irritable bowel syndrome-like symptoms, these patients do significantly worse in the COVID-19 pandemic and going on to have a cytokine storm. And with GI symptoms in a hospitalized patient, give them remdesivir rather than giving them favipiravir. Also because favipiravir is poorly tolerated in these patients, as favipiravir also causes diarrhea in a lot of patients. So that's my second indication. My third indication is definitely in patients who are hypoxic. So like steroids, in any patient who saturates at less than 94% or who's desaturating, I would, on mobilization, I would give them remdesivir rather than giving them favipiravir. Fourth, in any patient who's got a CT score of 14 or above and is in hospital for whatever reason, I would give them remdesivir. Fifth, if I've got a patient who is elderly with multiple comorbidities and a fever, mild to moderate disease even, my antiviral of choice would be remdesivir rather than being favipiravir, because I would like to reduce the viral load as early as possible in this group of patients because of the comorbidities that are associated. The fifth is non-evidence based. So there is no trial that says you can use remdesivir in mild to moderate disease, but I feel more comfortable doing it in the elderly patient with comorbidities. So those are my indications for using remdesivir.
Thank you very much. The message is very clear. That's right. Thank you so much. So, any other question, Dr. Pradyumn? Dr. Girish Mathur?
One thing, Dr. Apixaban. Any preference for Apixaban molecule?
Yeah, sorry, I forgot. I said I would say that. Thank you for reminding me. So the only reason Apixaban is because Apixaban is the drug which has got the most amount of evidence in the COVID-19 pandemic. There are 6 trials I know of, there are probably more than that, which have used Apixaban in a dose of 2.5 twice a day. And it seems to reduce the incidence of thromboembolic phenomenon post-discharge in the COVID-19 pandemic. This drug is metabolized quickly, seems to be renal friendly, and also has less hepatotoxicity. So it's more because of the side effect profile among the NOACs where it leads, as opposed to efficacy, which is why it's being used. So that's the only reason I use Eliquis. I think it's a safer drug as compared to the other NOACs. However, there are 1 or 2 trials, drugs like dabigatran, for instance, which have also shown good effect. But if you look at protocols from various countries, the reason it's always Eliquis is because that's the drug which has been used in the most number of trials till date.
I think we can take 2-3 questions from the viewers if there are any questions.
Yes.
Yes, sir.
Yeah.
Sir, can I ask a question?
Yes, sure, sir, sure.
Sir, good evening to all. Thank you, Dr. Raja. Wonderful discussion and deliberation. As already I have listened to all. I have one question. I'm Dr. K K Sharma from New Delhi. I have one question that due to the lack of availability of the beds in the hospital, the one practice is like those patients who are not requiring oxygenation and their SpO2 does not fall, they require the injectable therapy. They come to the hospital in the morning, get the remdesivir and low molecular weight heparin and the steroids in the injectable form, go back home, and this process continues for 5 days. Is it all right?
So in my book, it isn't, Dr. Sharma. Thank you for asking the question and thanks for the appreciation. I don't think it's all right. I'll tell you why it's not all right. So in the first place, if your patient is non-hypoxic, is not very unwell, and can isolate at home, why does he need the IV steroid, the IV remdesivir, and the IV the subcut anticoagulation in the first place? So I don't think if the patient does not have any symptoms of significant disease, moderate disease, severe disease, the patient should have the drugs in the first place. Second, if the patient has moderate to severe COVID, is hypoxic, has got a high temperature, has comorbidities, I would definitely admit them to hospital in some healthcare facility. I don't think we have reached the stage like Italy had, where there were absolutely no hospital beds. I don't know about Delhi. I know about Delhi. I know there are beds in Delhi. I know there are beds in Rajasthan. I think this practice of giving drugs to people at home or bringing them to hospital for a shot of remdesivir and sending them home is an unsafe practice. And in my understanding, the less we do it, the better it is for all of us. I mean, we're probably seeing the light at the end of the tunnel. The pandemic is probably coming to an end. So we will have beds for the remaining patients, and let's rather be safe rather than being sorry.
Thank you. Thank you, Dr. Dhar.
Thank you, Dr. Sharma.
Dr. Pareek, it's time to end because it's already 10 o'clock. So I request Dr. G.D. Ramchandani, as usual, vote of thanks to be done by Dr. G.D. Ramchandani, who is a treasurer of Scientific Committee Society APICON 2019. So Dr. G.D. Ramchandani.
Thank you, Dr. Pradyumn Sharma, for a nice introduction and nice this 8th series of Scientific Committee Society APICON 2019. And for that, he is working very hard for the past 2-3 months. And this is today is the 8th series. And today there is a wonderful discussion on this case, and they covered entire spectrum of the COVID from start day 2, day 3 to 21 days by Dr. Raja. So today is, I think, one of the best CME in this series of the this Scientific Committee Society. Before giving the vote of thanks, I request Dr. Girish Mathur sir to kindly announce. There is one announcement for all the audience and all the faculties. So I request Dr. Girish Mathur sir.
Friends, I think you all are aware that we are organizing an annual conference of Rajasthan API, a virtual conference on 26th and 27th December. So I request you all to please register yourself and join in large number and make it a great success. Thank you.
And I request Dr. K K Pareek sir also,
Yes, sir.
chairman of this conference, for kind word.
No, it had been a excellent deliberations, and I mean very clear messages for everything related to COVID infection. So I think if Dr. Dhar is free on 26th or 27th, we can have his lecture also during the conference on COVID, because we have got a session on COVID. So I request him to kindly, if you are free, you can oblige us by your lecture during the conference on COVID.
Yeah, we will. So, Dr. Raja, do you agree? Just
So Dr. Sharma, Dr. Pareek, Dr. Mathur, thank
Yes,
you
sir.
very much.
Yes, sir.
My only problem is that 25th to 27th, I'm off on a family holiday for 3 days.
That's right.
I'm
That's
not there.
No, good.
However, if you want
After
me to record a talk and send it to you, like we did for this one, I mean, Shubham did it for us. And I mean, I also need to thank Shubham. He was absolutely brilliant in the way he presented the case. Shubham is a boy from your state, and we are very proud of him in Kolkata. So he's a great lad, and I'm sure he'll go back to Rajasthan and do well for himself at some point of time. I hope he stays with us in Kolkata, but I'm sure he'll go back to Rajasthan at some point. But
very
as far
nice,
as,
very nice. We'll have him.
yeah. So I could record a talk if you want and send it across to you. I probably wouldn't manage to be physically there. I would love to, but I don't think I'll manage this time. But Dr. Pradyumn Sharma and arrange for a recording if you are keen for that. I am very happy to do that if you want.
I'll be in touch with you, sir.
And it's really lovely that after doing so much hard work, you are going on holidays. So we would like that you should enjoy your holidays. It's really good. And Shubham, you know, we have got a lot of friends at Kolkata because of API. There are so many friends in Kolkata. So, and Shubham, you are most welcome to Rajasthan. You are really, as Dr. Dhar said, you are a brilliant person, brilliant pulmonologist. So we would be very happy to welcome you in Rajasthan. So thank you very much, Dr. Shubham and Dr. Dhar, for a great deliberations. And thank you, Pradyumn, Dr. Girish, and Dr. Ramchandani. So you can conclude, Dr. Pradyumn Sharma, you can conclude it now.
And not to forget Dr. Vivek Singh, sir. Dr. Vivek Singh from Hyderabad was
Vivek Singh, yes.
I also express my sincere thanks to Dr. Vivek Singh for a very deliberation on lung transplant.
Are you there, sir? Vivek Singh? No.
Probably has left.
Before concluding this today's CME, that we know that since March, that every week or every day the things are changing. Recently in Delhi, around 12 or 13 cases of mucormycosis were reported by ENT surgeons, and 5 out of them 5 were died because of that and brain involvement. Some of them lost the eyesights because of this black fungus. So what is your experience about this, Dr. Raja Dhar? Because whether it is a coincidence or it's induced, or commonly we are seeing in the immune compromised patients in day-to-day practice. So what is it?
We have seen, so we've not seen mucor, Dr. Ramchandani, but we have seen quite a bit of aspergillus. So especially in the group of patients who have a MAB. So if they have had tocilizumab, for instance, secondary infections, especially fungal infections, especially aspergillus, even atypical mycobacteria, or even TB is something that we have seen in this population of patients, especially in the long term. We've seen about 5 patients with concurrent TB and COVID-19. A lot of these patients have had a MAB and they're immunocompromised, or they've had steroids for long periods of time. I don't think the COVID by itself predisposes to fungal infections. I think it's more the diabetes, the use of steroids, the use of drugs like tocilizumab, which predispose you to the fungal infections, be that mucor or be that aspergillus.
Thank you, sir. Thank you.
Thank you so much, sir. Dr.
Sir, any role of baricitinib? Any role of baricitinib?
Yes, that's right.
So I have no clue. So I know the theory behind it, but I have no practical experience with it. The trials look promising, but I don't think we've got enough evidence, and I have never used it personally till date. But I mean, I have read the literature like you have, but I wouldn't be the right person to comment about it.
The basic issue with the baricitinib is that, in fact, it is chances of thrombosis is high. Number 1. Number 2, you cannot do below 2 lymphocyte count. If the lymphocyte counts are less than 200, you cannot give this drug. Number 3, long-term lung malignancy is high. Because I just attended one NGCR, this is a grand round of All India Institute they have done with the University London. So again, they have a clue about the baricitinib and they have keeping their fingers crossed. And in the personal though, they do not have an experience, but I have gone through the drug. I bought it for one of my relative. I got it from Delhi. That drug is costing 17,000 rupees for 7 tablets. But they have a very strong box warnings are there. So we could not use it. That's the basic choice. That's
Right. Okay. Thank you. Thank you.
Thank you very much.
Thank you, sir.
Thanks, thank you
So
very
we
much.
conclude now.
Thank you,
I
sir.
think Dr. Raja is also
Yes.
Actually, he was
a long period.
You have given us
don't
such a
want to
long
leave you, sir.
schedule.
I don't want to leave you guys either, so that's why I'm sat
Thank
here.
you, sir. Thank you.
Thank
Thank
you so
you.
much.
Thank you.
Thank you so much.
Thank you.
Thank you, sir.
Thank you, Dr. Raja Dhar,
Thank
Dr.
you.
Shubham Sharma, and Dr. Vivek Singh for a wonderful CME today for clarifying all the things in the COVID. And thanks to Dr. Pradyumn for really is a captain of the today's scientific committee chairman, scientific committee society. And special thanks to Dr. K K Pareek sir and to Girish Mathur sir for sparing time and encouraging the new all us to do regularly this CME, and we are conducting this today's is the 8th CME. So thank you to all, and thanks to all the participants and delegates for attending this CME. Thank you very much, sir. Thanks to all.
Thank you
you,
everyone.
sir.
Thanks for inviting us.
Nice of you. So
परेख
nice.
साहब, डॉक्टर चुक बोल रहा हूँ उदयपुर से.
जी सर. चुक साहब नमस्कार.
गिरीश.
हाँ dear. चुक
सर.
Dr. Chug.
देश में सर ये जो आपके
हाँ.
अच्छे स्पीकर सब लाते हो, उनका अगर फोन नंबर भी
क्या
कई क्वेश्चन जैसे भी टाइम खत्म हो गया तो कोई क्वेश्चन पूछना हो तो पूछ ही नहीं पा रहे, ऐसे कभी हो तो अगर आप डाल दें तो अच्छा है.
हाँ.
फोन नंबर
सर आप पूछो ना, बीच में मना किसने किया आपने? आप आगे हाथ खड़ा कर दो तो वी विल इनवाइट यू.
चुक साहब तो शुरू क्लास में शुरू से क्वेश्चन पूछते हैं. रामचंद्रन जी 73 से देख रहा हूँ क्लास में खड़े होकर सबसे पहले क्वेश्चन पूछने वाले चुक साहब. चुक साहब आवाज नहीं आ रही.
हाँ आवाज नहीं आ रही बॉस की. वो
हमारे क्लास में कोई क्वेश्चन पूछे नहीं पूछे, चुक साहब जरूर पूछेंगे सर.
इंटरनेट